Look at this animated loop. It represents the strictly closed system of human iron physiology. Excess sodium or potassium is simply excreted by the kidneys. Iron operates under a completely different physiological constraint. The human body possesses absolutely zero mechanisms for active iron excretion. This schematic breaks down our total body iron baseline, which sits between 3 and 5 grams, or roughly 50 milligrams per kilogram. We divide this inventory into 3 distinct functional compartments. The vast majority, 60 to 70%, equating to about 2.5 grams, is bound within the circulating red blood cell mass, specifically coordinated to the porphyrin rings of hemoglobin. The secondary pool is dedicated to storage. 20 to 30% of our total iron is sequestered primarily inside the liver, spleen, and bone marrow. The remaining 5 to 10% resides in muscle tissue as myoglobin and within cellular enzymes that require iron at their active sites, such as cytochromes, catalase, and peroxidase. We lose roughly 1 to 2 milligrams of iron daily, but this loss is entirely passive. It occurs strictly through the continuous sloughing of epithelial cells from the gastrointestinal tract, skin shedding, and menstruation. This inability to actively excrete the metal creates a severe physiological hazard. Free, unbound iron is highly reactive. Through the Fenton reaction, it catalyzes the formation of superoxide and hydroxyl free radicals, causing widespread cellular damage. Because the metal is toxic and cannot be expelled, systemic iron homeostasis relies entirely on controlling its entry. The body bottlenecks its iron regulation at a single point, absorption at the duodenal mucosa. A typical daily diet contains about 15 milligrams of iron. To maintain equilibrium against passive daily losses, the duodenum absorbs only 1 to 2 milligrams. This diagram isolates the mucosal interface of the duodenum. Notice the dietary non-heme iron arriving at the apical brush border. It presents in the oxidized ferric state, an Fe3+ ion. Enterocytes adhere to a rigid absorption rule. Iron must be reduced to the ferrous state, Fe2+, to enter the cell. Gastric hydrochloric acid and dietary reducing agents, like vitamin C, facilitate this valency shift, converting the ferric iron into ferrous iron. Once reduced, the ferrous iron passes through the apical membrane via a specific transport protein, divalent metal transporter 1, or DMT1. Dietary heme iron from meat follows a parallel pathway. It enters the enterocyte completely intact via a separate heme transporter, after which intracellular heme oxygenase cleaves the porphyrin ring to release its ferrous iron into the shared cytoplasmic pool. This strict valency requirement creates a specific clinical vulnerability. Patients taking proton pump inhibitors or antacids elevate their gastric pH. This alkaline environment prevents the reduction of ferric iron to ferrous iron, directly blunting duodenal absorption. The biochemical criteria at the apical membrane function as a physiological gatekeeper, isolating the systemic circulation from unregulated heavy metal intake. The journey does not end inside the enterocyte. The ferrous iron must cross the basolateral membrane to reach the plasma. Looking at this continuing diagram, the ferrous iron exits the cell through ferroportin. This is the only known cellular iron exporter in the human body. Upon entering the plasma, the rules of valency flip. To be transported safely, the iron must immediately be reoxidized to the ferric state, Fe3+. This ferric iron is then loaded onto transferrin, a plasma beta-1 globulin synthesized by the liver. Each transferrin molecule carries exactly 2 ferric iron atoms, shuttling them safely to the bone marrow and target tissues. Under normal physiological conditions, plasma transferrin is only about 30 to 35% saturated, leaving a massive buffer capacity to bind unexpected free iron. The continuous toggling between ferrous and ferric states ensures a highly reactive, toxic molecule remains biochemically locked throughout its transport cycle. To synthesize new hemoglobin, the bone marrow requires approximately 20 milligrams of iron every single day. The 1 to 2 milligrams of dietary iron absorbed by the duodenum falls vastly short of meeting this daily erythropoiesis demand. This animation illustrates the true engine of the iron economy, the reticuloendothelial system. As circulating erythrocytes reach the end of their 120-day lifespan, tissue macrophages phagocytose them, extracting their iron and releasing it back to transferrin in a continuous high-volume recycling loop. Excess iron recovered by these macrophages, or delivered to the liver, is sequestered in two specific biochemical forms, ferritin and hemosiderin. Ferritin provides immediate water-soluble storage. Free iron binds to an outer protein shell called apoferritin, neutralizing its reactivity while keeping it readily available. When cellular storage capacity is overwhelmed, the iron condenses into hemosiderin. These are insoluble, granular deposits housed inside lysosomal membranes, indicating long-term storage or pathological excess. Dietary intake merely tops off the system. The body maintains adequate iron levels almost entirely through this rigorous internal recycling by macrophages. The exact mechanism linking dietary absorption to macrophage recycling relies on a single peptide hormone synthesized by the liver, hepcidin. This diagram demonstrates hepcidin's mechanism of action. It acts as the master regulator by binding directly to ferroportin exporter channels on both enterocytes and macrophages. This binding triggers the rapid internalization and physical degradation of those channels. When total body iron stores are high, the liver secretes more hepcidin. With ferroportin degraded, iron cannot exit the enterocyte and remains locked inside the cell's cytoplasm. This creates the mucosal block. The trapped iron is stored as ferritin and permanently removed from the body when the gut epithelium naturally sloughs off and is excreted in the feces every 3 to 4 days. By destroying the only exit door, the hepcidin-ferroportin axis resolves the excretion paradox. It regulates the total iron load by ensuring excess metal never reaches the plasma compartment. This regulatory pathway is highly sensitive to surgical stress and systemic inflammation. Inflammatory cytokines, particularly interleukin-6, aggressively upregulate hepatic hepcidin release. The liver executes this response regardless of the patient's actual total body iron stores. The resulting high hepcidin levels shut down ferroportin system-wide. Iron becomes trapped inside macrophages and enterocytes, physically unable to reach the bone marrow. We identify this clinically as functional iron deficiency, or the anemia of chronic disease. As shown in this split screen, prescribing oral iron pills to a preoperative inflamed patient often fails. The elevated hepcidin ensures the oral iron is trapped by the mucosal block, yielding zero bioavailability and severe gastrointestinal distress. Intravenous iron bypasses the mucosal block entirely. Administering iron intravenously loads the metal directly onto transferrin to optimize red cell mass prior to surgery. Recognizing the inflammatory hepcidin axis provides the physiological rationale for shifting modern patient blood management away from oral supplementation and toward targeted IV iron protocols. There is a severe hazard to bypassing physiological intake. Because we lack a pathway to excrete iron, repeated life-saving red blood cell transfusions deposit an unmanageable iron load directly into the patient. This manifests as hemosiderosis. Massive, toxic hemosiderin deposits accumulate, eventually causing severe organ damage, primarily targeting the liver and heart. Reviewing the broader erythropoiesis cycle, while the kidney produces 90% of the body's erythropoietin in response to hypoxia, the liver produces the remaining 10%. This remaining fraction becomes critical for sustaining RBC production in patients with end-stage renal disease. This animated diagram captures a final, high-yield oxygenation concept, the double Bohr effect at the placenta. Fetal carbon dioxide crosses to the maternal side, dropping maternal pH and right-shifting her oxyhemoglobin dissociation curve to offload oxygen. Simultaneously, the fetal curve shifts left as it loses CO2, increasing fetal oxygen affinity. From the valency requirements of duodenal transporters to opposing oxygen shifts at the placenta, mastering these precise micromechanisms forms the foundation of rigorous anesthetic practice.